Welcome everyone to the first session of Fertility Network UK's 2024 LGBTQ+ Pathway to Parenthood course. My name is Bethan, my pronouns are she, her, and I work for Fertility Network UK, providing support to people and leading on our LGBTQ+ specific support. Tonight is the first session in the 6-week course that will look to cover the various options that we as LGBTQ+ people have in creating a family. And each week we'll be joined by experts in their fields to focus on one topic. This year we'll be covering not just our options within fertility clinics, such as surrogacy, IUI, IVF, shared motherhood and fertility preservation, but also this course will look at adoption too. As a reminder, these sessions are being recorded. You'll be able to watch them back as we'll share them on our YouTube channel. And for reassurance, we're only recording the speakers. Please do ask any questions you want on the topic by submitting them in the Q&A channel, and we'll get through as many as we can. So without further ado, let's begin our first taster session on the fertility treatment options we have as LGBTQ+ people. I'm absolutely delighted to be joined by Dr. Gilling Smith, CEO and Medical Director at the Agora Clinic in Brighton. Welcome, Carole, and over to you.
Thank you very much. Absolute delight to meet everybody. So I'm Carole Gilling Smith, Dr. Carole. I am in charge of the Agora Clinic, which is a very inclusive clinic. I've been a long-standing ally of the LGBTQ+ community, and it's an absolute delight to try and unravel some of the mysteries of the different pathways. I'm going to use some slides, and it's really to try and help people visualize. I think visualizing the pathways is really important. And I'm not going to be able to cover absolutely everything for everybody. It's kind of a taster of all the different possibilities that there are for the community to be, to become parents, whether you're single or in, a long-standing relationship. So I've kind of called it Pathways and Pitfalls because I want to cover, if I can, an introduction to how to understand your fertility, what tests are really important. I'm going to cover donor sperm treatments, insemination and IVF, shared motherhood, a little tiny bit about choosing your donor and sort of talk both about sperm and egg. And that will lead me beautifully into surrogacy, which often involves donor eggs. So a little touch on egg donation as part of surrogacy. And then last but not least, transparenting, which it's a whole lecture on itself, but everything I say is almost in a sequence where it builds on knowledge so that the next part makes more sense if you understand the sort of basics of IVF. So if you are trans and you want to find out about egg freezing, please don't switch off, wait till the end. You will understand it better for watching the whole thing. And then the pitfalls is how to choose a clinic. And I think it's just sort of key points really. So starting off with your fertility test, and I think it's really important that, I talk about eggs and sperm. I'm not going to be talking about his and her. I'm not really going to be talking about things that you see in traditional clinics. So eggs are really important. Doesn't matter if you're, whatever treatment you're doing, if you're a donor of eggs or you're actually wanting to use eggs for your own treatment, it all happens before you're born. Every single person who has ovaries has all their complement of eggs fully made by the time they're halfway through their mother's pregnancy. And that's around 8 million eggs. And by the time you're born, you've sort of lost 3/4 of the eggs. You have about 2 million eggs between the two ovaries. And this sort of what we call exponential loss of eggs, as you can see in the graph, continues until puberty, quite a sharp loss of eggs before we sort of have a more steady loss of eggs on a daily basis during your reproductive years, which takes you through till your sort of late 30s, early 40s. Your optimum fertility really is reached before you're about 32, 33. And then by the time you get to 35, you will start to see genetic errors occurring in the eggs with increased frequency. And that's why pregnancy rates fall gradually, particularly from the age of 35 onwards. And they're really quite low in your 40s and particularly mid-40s onwards, with the menopause being the time when your periods stop and you've got just a couple of hundred eggs left in the ovary. Now, so you're losing both eggs and quality of eggs, but the most important thing that will determine your success in any situation of conception is your age at the time those eggs are used. which is why preserving your fertility is better done before the age of 35. And, you know, if you're thinking of having children and you're not ready, creating embryos to freeze is a good idea before your age is 35 or more. Now, how do we measure your fertility? Well, we do an ultrasound scan of your ovaries, and that's because you've made all your eggs that are asleep in your ovary, but you wake up eggs all the time. Every day of your life, you wake up, a new cohort of eggs appears, and when they're awake, the egg sits like this diagram shows here. An egg is sitting in a little sac of fluid in the ovary, and we see this as black circles on our ultrasound scans. We tend to do our scans internally, a bit like an internal examination, but they don't hurt, those examinations. They're not painful. But if you're trans and you're kind of anxious about internal examination, the scan can be performed abdominally. The picture is not as clear, but as you can see, we can count the number of follicles, and we call this your antral follicle count. And we also measure the hormone that's made by the cells in those little sacs, and that's your anti-Müllerian hormone, or AMH. And these two numbers are quite important in us measuring your ovarian reserve. That is not going to be a measure of your egg quality. Remember, your age will be the important factor there. But the ovarian reserve gives us an idea of how many eggs you could produce if you were to have an IVF cycle. IVF cycle either to get pregnant or to freeze your eggs or freeze your embryos. It's therefore a really important number when you're trying to understand your own fertility, or when we are trying to select egg donors. That's why that's an important test. Now, when you come to the fact that we always have a lot of awake eggs in the ovary, it translates into why IVF can be a successful treatment, because each month only one of your eggs that's awake is grown by your hormones that are produced from the brain to ovulate an egg. Very, very occasionally people ovulate 2 eggs at once. But knowing that you've got extra eggs that are awake, what we can do is give you injections of these 2 hormones, FSH and LH. These are hormones made by the brain that are made in the natural cycle. By giving you instead daily injections at a certain dose, we can encourage more of your awake eggs to grow than they would do normally. And that's how we can collect a larger number of eggs, for example, for IVF treatment or to freeze eggs. And that's the basis of IVF, which I'm going to come on to. Now, on the lower part of this diagram, I'm just going to show you the other part of fertility, the fertility pathway. So we're going to create, obviously, embryos, fertilized eggs, and we're going to be wanting to put the embryo into a uterus that's got a good lining. And what the lining does during your menstrual cycle is thicken up. And the hormone that's super important in receiving or preparing the womb lining to receive the embryo and in pregnancy is called progesterone. So you'll find that we use progesterone in our treatment pathways to thicken up your womb lining if you're going to have an embryo transfer. Now that hormone might come through your natural cycle. So for example, when we do surrogacy, our surrogates are often allowed to ovulate naturally, and their womb lining will be prepared by their own progesterone. But in IVF, because of the hormone drugs we use, we are often having to give you additional progesterone. One final little point while I'm on this diagram. This hormone, LH, is your ovulation surge hormone. This is a hormone you can measure at home by doing a urine test. So first of all, it can be useful to know your own natural cycle. That's a test that you can do, for example, if you're having donor insemination, which I'm going to talk about. But the other thing that's important about this, we do not want this hormone to appear during an IVF cycle. We have to knock it out by using a certain injection that blocks it. And then we give it to you ourselves at exactly the right time to prepare you for egg collection. So enough said on that diagram, but there's lots of information there that's going to all make sense in a minute. And the nice thing about these, the follicles that we can see on ultrasound scan is we can watch them grow. So that's how all the monitoring is done in the clinic when we do an IVF or an IUI, donor insemination cycle, or an egg donation cycle. We can watch the follicles grow and plot them out, and the doctor can then review to see whether you're ready to have your eggs collected or have your insemination. Now, let's look at the sperm. Sperm is not formed until puberty, and it takes about 3 months for sperm to grow and be fully mature before it's ejaculated. And in that 3 months, all sorts of things you put in your body can affect the quality of sperm. And when we do a sperm test, we look at 3 things. We look at the sperm count, the number of sperm, how the sperm is moving forwards, particularly in IUI. That's terribly important because the sperm has got to get from the top of the uterus through the fallopian tube to the eggs. And we look at whether the sperm is shaped normally. Now, as you can see in this little diagram, you see this is a normal, beautifully normal sperm. That's what we'd love. We'd love 100% of the sperm to be like that. But in human beings, we tend to find about 95% of the sperm is like this stuff, the stuff on the right. It's got big heads, small heads, 2 tails. In that 72 days, something has gone wrong in the way the sperm is formed. And that's normal. That's absolutely normal. As long as 5% or more of the sperm is normally shaped, statistically, there's a good chance of conception. So when we do a sperm test, if we find that you have less than 32% of the sperm moving forwards, a count of less than 15 million sperm in every mil, and most people will have about 2 to 4 mils in their ejaculate. And if you've got more than 96% sperm, which is abnormally shaped, that will reduce the fertility. Lots of ways of getting around that I'll talk about. You can inject the sperm into the eggs and so forth, but that's how we measure the quality of sperm. Another measurement we do, not all clinics do this, but we offer additional tests such as measuring the DNA health of the sperm, because I find this particularly useful in those considering surrogacy, intended parents considering surrogacy, because it's kind of going into the detail, the genetic detail of the sperm. We know that in people with eggs, we know that the age of the person who has the ovaries is important in determining how genetically healthy the egg is. And likewise in sperm, the DNA fragmentation index that's inside the sperm, which we can measure with a special test, will tell us how genetically healthy the sperm is. And that can be really useful, because what you don't want to be doing is embarking on creating embryos with your sperm and finding a lot of these embryos are genetically not healthy. Now, one final test. Now, this test is often not required in those from the LGBTQIA community. It's a test of whether the fallopian tubes are open. It is a simple ultrasound scan. We do it here at the Agora, and it involves passing some contrast fluid through the uterus, and it will hopefully come through the tubes and be visualized on scan, so you can see that the tubes are open. It's really simple. It's not uncomfortable. It's done as an outpatient procedure by a medical doctor, and it gives a yes or no answer. Who needs it? Well, if you've got a history of having had chlamydia or something that involved surgery to your ovaries, for example, if you had a cyst removed, or previous pelvic infection, we would advise you to have this test if you are considering insemination of sperm into the uterus, because the tubes have to be open for that technique. It's not a particularly required procedure if you're having IVF anyway, if you're having IVF with donor sperm, or if you're freezing eggs, or if you are doing surrogacy. But it is particularly useful in a small group of people who are undecided as to whether they should do insemination of sperm. Right, moving on now, we're going straight into the treatments. So first treatment is donor insemination. Now, I'm not going to talk to you about insemination of sperm at home. There are risks. There are risks because there is not the same level of screening of the donor. There is not the same level of screening of the sperm quality. There aren't the necessary legal parenthood forms put in place to protect the donor and to ensure that if you are in a same-sex relationship, both of you are the legal parents. And you don't have the option of having fertility testing to ensure that this is the right technique. So if you are thinking of doing home self-insemination, think carefully, perhaps have a consultation with your clinic just to make sure it's the right thing for you. When you come to a clinic, of course, the donor sperm will come from a donor sperm bank, and by that, it will be fully screened. I'll talk about how to select your donor later in the talk, and you'll see the sort of stringent requirements about the age of the donor, the sexual health screening of the donor, the medical screening of the donor, and so forth. And the donor sperm is in little straws or ampules and vials, frozen, and it has been fully screened to exclude the risk of infection to yourself. And the other benefit of the clinic will be that you will complete consent forms, allowing you, if you're not married or in a civil partnership, for both of you to be the legal parents. And that has to be completed before conception occurs. In terms of the actual practical part of the donor insemination, you will sort of have a consultation to explain the process to you, but the donor sperm, when it has been ordered and received by the clinic, will be held securely until the day it is required to be thawed and used. You will have monitoring of some description. Certainly at the Agora, our monitoring is usually through ultrasound scanning of your cycle to make sure you're developing a follicle. We can use either home testing kits for ovulation or just by observing the actual size of the follicle has reached 17 or 18 millimeters. And then we trigger ovulation by giving an injection of the ovulation hormone. And then we will prepare the insemination to take place 36 to 40 hours later in the clinic. And on that morning, one single vial of the donor sperm you've purchased will be thawed, centrifuged, and prepared, concentrated into a small volume of about 1 ml, and a very soft tubing will be passed through the cervix into the uterus, allowing the sperm to swim up both tubes to meet the egg just as it is being released. Normally, fertilization takes place in the outer part of the tube, and we estimate, certainly if you're sort of 35 or younger, a 15% chance of pregnancy per insemination, 45% chance of being pregnant after 3 consecutive inseminations. But as you get older, the chances will start to fall, particularly over the age of 40. You have to wait 2 weeks, and then if you're not successful, you could have another cycle, provided you've got donor sperm in storage. Is it painful? No, it isn't. I think it's less painful in a clinic because normally we're extremely experienced at doing internal examinations, unlike perhaps GPs, surgeries where they do cycle smears. And you can have your partner with you, and it can be very, very straightforward. We have to place the obviously the instrument, we call it speculum, in the vagina, and that can be some people find that a little bit uncomfortable, but for most people it's relatively straightforward. It takes 15 minutes to 10, 15 minutes, you're in the room, and then you can go home and nothing specific to do afterwards. If you have an irregular cycle, we can give you some tablets to help you produce an egg each month. It's called ovulation induction to increase your chances. IVF is the next step up, and I find increasingly couples are coming to consider IVF treatment because the chances of pregnancy are probably per cycle is 3 times higher. It offers certain advantages, which is you can create embryos for the future if you don't get pregnant on your first cycle. It provides more information about the quality of embryos, quality of the eggs. But it is obviously a more costly procedure. Just talking you through it, we start off here on the left-hand side of my diagram with the 2 weeks, well, it's normally about 10 to 12 days of daily injections. Now, these injection hormones are, unfortunately, they're destroyed by the acid in the stomach, so we can't give you them in tablet form. But the injections are done just under the skin, usually in the skin of the tummy, that flabby bit. just under the skin. And we find that everybody finds it obviously a bit sort of daunting to do injections themselves, but once we've shown you and taught you how to do them, they're very easy to do, and your partner can help your friend or parent how to do these injections. You would need to be monitored, which is, when we come to choosing a clinic, it's also well worth choosing a clinic that's not too far from you, because you normally need to come in for 2 to 4 ultrasound scans during that first 2 weeks of your cycle after your period, where we're watching the sort of little follicles growing until we get a little collection of follicles of 18 millimeters or more. So that's normally about 10 to 12 days. And once we see that, we're ready to do the final trigger injection. So we use 2 different types of injections. As I previously mentioned, we can't have you ovulating these eggs too early. So one set of injections is designed to stop you ovulating, and the other one is to stimulate the eggs to, the follicles to grow. When we're satisfied you've got a good number of follicles, at my clinic we do blood tests as well, hormone blood tests, but I know some clinics don't do that. So we're monitoring very carefully with scans and blood tests, and then we have medical consultants here at the clinic review everything, review all the scans, and make the decision as to whether you're ready to have your eggs collected. And then you have a final trigger injection. That injection will allow you to have your egg collection normally 36 hours later. You'll come in and have that, and some form of sedation will be given to you, because you're basically going to have an internal scan with a tiny, tiny little needle going through the top of the vagina. It doesn't really hurt, but the thought of it isn't very nice. So we do like people to be a bit sedated. And that needle will go into each of the little follicles to collect the eggs, and the test tube containing the eggs is passed to the laboratory. And a single vial of donor sperm will be thawed and mixed in with the eggs. And for 5 days, we will culture the eggs that are fertilized to be able to create a blastocyst, which are day 5 embryo. And that will then be transferred into your uterus. And as you can see, we can also do it to freeze an embryo or to transfer it into your partner's uterus. This is the building block of all the treatments I'm going to talk about tonight. Injections to create enough eggs to collect, collecting the eggs, creating embryos, and embryos can either be stored, transferred into a uterus, or allowed to perish if they're poor quality. So just having a quick look at the drug side of things, the medication side of things. Is it a lot of medication? Well, we tailor the medication to your fertility hormones, your ovarian reserve. So having done the initial test to find out how many eggs you have awake, the dose of drugs will be tailored to that. Often we add in your age and your weight, depends on the clinic. And that should give us a steady response. We would always prepare you with a medical consultation, followed by a nursing consultation, where everything is explained to you, all of your questions are answered. You have some injection teach videos, and consent forms are completed. You go on then to have your treatment, which is often around the cycle. And when we do the injections, we will normally scan you after the first 5 days and then every other day. And as I say, the trigger injection is absolutely critical. So it prepares the eggs for egg collection, and that's to given 36 hours before the actual egg collection. This is a diagram showing you the egg collection process and how it works. So the needle goes into each little sac of fluid and is sucked through the fine needle into a test tube. And it's all done under ultrasound guidance. You have an internal scan to allow the doctor to collect your eggs. This is the actual appearance of an egg. There's the egg. And what you see around the egg here are called cumulus cells. These are the feeding cells that surround the egg when it first comes out. Now, if we're using donor sperm that is top quality donor sperm, probably from a donor sperm bank where all the motility is good, count is good, we would naturally be doing IVF, which is where after the eggs have been collected, we mix the eggs and the sperm in an incubator dish. They're in a little Petri dish and they're placed in the incubator. And overnight, a single sperm should enter each egg. It's very, very important. If you're using a known donor with poor quality sperm, or your donor sperm does not thaw out well, then we use a different technique, which is called ICSI, where we inject a single normal-looking healthy sperm into each egg. ICSI should not be performed routinely on every single patient. It's more costly, at least £1,000 more, and is usually not required with donor sperm unless there is a problem with the quality of the sperm. So if a clinic is charging you to do ICSI, question it, it may not be necessary. This is a picture of incubators. There are numbers of different incubators in different clinics, and we certainly use a lot of the time-lapse incubator here at the Agora, which takes a little picture of the developing embryos every 10 minutes, giving you a really deep insight into what is actually happening to the embryo, and it leaves the embryo undisturbed in its environment for the full 5 days while it develops. Now, the following morning, we're going to see which eggs have fertilized. So here we can see 3 different eggs. Each egg has got a shell. Inside the egg, you will see circles. This is what we're looking for, a 2PN, which is 2 circles indicating that a single sperm has entered the egg and the genetic material from the sperm and egg are now combining. 1 2PN is incorrect fertilization. 3 is incorrect fertilization. 0 is no fertilization. 4 or 5 PN is abnormal fertilization, often egg related. So when you're doing an IVF cycle, whatever you're doing it for, if you're mixing sperm and eggs, you should get a phone call from your embryologist telling you how many of your eggs are fertilized normally. And in most clinics, you would get 60 to 70% of your eggs fertilizing normally with IVF or even ICSI. Say you had 10 eggs, we would like to see around 7 as a minimum that are fertilized normally and a really good result. Then we have to find out which of the eggs are actually going to make it to the embryo stage. So we keep them in the incubator for 5 days, during which time, over the first 48 hours, the cell will divide into up to 4 cells. By the 3rd day, we should have 8 cells available. By the 4th day, you see all of the cells are coalescing and compacting. It's called a morula. And by the 5th day, you start to differentiate cells which will form the baby, this little clump here, and a ring of cells which will form the placenta. And this particular blastocyst, as we call it, it's even started to hatch out of its shell. That's the best embryo we can have ready to transfer. And the reason we're waiting 5 days is just like, the Olympic athlete that's running in the race. You need a certain distance to differentiate the best runners from the slower runners. And here it's not so much a question of speed, it's a question of quality. And we would, again, taking 10 fertilized eggs, you may not even get, 1 top grade blastocyst, but certainly when I have, patients who are same-sex relationships or single women who are not, who are socially infertile, who are not actually infertile in the sense of heterosexual couples who've been trying for years, we often see really good rates of embryo formation. We often see several embryos reaching this day 5 stage. And so we have enough to transfer 1 embryo and end up with several other embryos, which we can freeze for future use. So the embryo transfer itself is nice and straightforward. It's not going to require any form of anesthetic. It's a little bit like the IUI procedure. It can be done as an outpatient. A soft, flexible tubing is passed through the neck of the womb, and under ultrasound guidance, usually a tummy ultrasound, we will place the embryo in the center of the uterus. And this, again, normally done by a consultant or very senior fertility nurse. There's no need to rest afterwards. You can go home and carry on as normal. And you will take, at this point, additional progesterone, the hormone I said was very important in preparing the womb lining. And do your test normally 9 days after the transfer. Now, you will see different success rates by different clinics, and you just need to be a little bit careful when interpreting success rates, because different clinics have different cohorts of patients. Here at the Agora, for example, we have 60 to 70% NHS patients that we take, have often been on a waiting list for years and years, and we're not selecting patients at all. Some clinics are potentially not treating patients with very low egg reserve. They may actually suggest that those patients have egg donation and so forth. So very, very important when you're looking at different clinics not to be too focused on success rates, because they will not tell you what you personally will be able to achieve. You need to actually have a consultation, discuss your situation with the consultant and say, well, what are the chances here? But you do obviously see from this graph, I'm just showing the Agora clinical pregnancy rates. Now we've got a problem in that the regulator, the HFEA, requires all clinics to submit their pregnancy rates for verification and for publication, and they are very, very behind in publishing latest results from clinics. So that's another problem that can confuse patients, in that some of the clinics are producing data that hasn't been verified. We've got on the HFA website our success rates for 2019, 2020, but nothing else has been published since. But we do place on our website up-to-date figures so that people have an indication. But no graph will tell you what exactly you will expect to achieve, because that is very much dependent on not only your age, but your ovarian reserve, whether you've had previous cycles, whether those cycles have failed. So why would you do IVF rather than IUI with donor sperm? Well, higher success rate, about 3 times higher than IUI, which will reduce potentially your time to pregnancy. Certainly it's a better option if you're older and you have a lower egg reserve. It offers you the option of freezing your embryos or preserving your fertility, particularly if you've got a lower egg reserve or you're older and you may want a second or third child. You might have a pregnancy from one cycle, but you've frozen some embryos for the future. You can use the technique to donate your eggs to your partner, and we will just cover shared motherhood in a minute. It does obviously make more sense because sometimes people end up with IVF after 3 to 6 cycles of failed donor insemination, but it is more invasive and more costly. May give you some side effects. I'm not going to say that taking fertility drugs is without side effects. Some people get no side effects, others do feel much more hormonal, might feel a bit of a headache, might feel bloated. There's small risks with IVF, and probably a couple more visits to the clinic for monitoring. Now, just going through shared motherhood, we do exactly the same thing as in the previous cycle. We create embryos, but the person who's donating their eggs does not then start to prepare for the embryo transfer, does not take progesterone, because their partner will take hormonal medication to prepare their womb lining, normally tablets of estrogen and pessaries of progesterone, in order to have the embryo transfer. The additional things that have to happen with shared motherhood involve screening of both partners. Now, under our rather archaic regulatory regulation that we have still in place, the person who is donating their eggs is screened, or has to be screened, as an egg donor. The regulators, the HFEA, have put forward to Parliament a proposal to modernise the Act in many different ways to fit in with modern parenting. And one of the things that we know will change is the screening requirements for same-sex couples who want to consider shared motherhood. Most clinics have now therefore moved to a less stringent form of screening to try and save costs for patients. So do shop around some clinics. I mean, certainly for us at the Agora, we are offering patients the option of not having full screening, because it is sitting in Parliament awaiting formal legislation approval. So it should be, hopefully in the next few months, we hope before the end of the year, officially not required to do the full screening as an egg donor. But under current law, that still stands. You can, of course, freeze surplus embryos, and it's important that you have that option, because success rates are not 100%. So if that first cycle fails, you've then got a potential second or third chance if you've been able to freeze embryos. So you might actually decide that you want to freeze embryos anyway, not go ahead with transfer. I see quite a lot of patients who do this. They decide that they are either single or in a same-sex relationship, wanting to be sure that they're going to have children or have as much chance as possible before they get too old, but they're not, due to various reasons. It might be career, it might be other things that are getting in the way in life. So they will come forward and select a sperm donor that they both want or feel happy with using, and each will come through, do a cycle, and create embryos, with the possibility of donating to their partner, so carrying out the screening to allow them to donate to their partner. It's really, really helpful. Nothing is guaranteed. Even in the situation where you freeze your embryos, we cannot guarantee a pregnancy, but you are obviously giving yourself a better chance than leaving it until you're older, when your success rates are dropping. Now, what makes a successful pregnancy? Well, it's a combination of two factors. It is the genetic health of the embryo, and that is largely determined by the egg provider's age. So 35 or younger gives you the highest success rate. As you get older, decreasing success rates with your age, and how receptive your uterus is. So people that have a combination of a low genetic health of the embryo and poor receptivity of the uterus just don't get pregnant. We call that implantation failure. Embryo can go back, but nothing happens. But if they've got a poor quality embryo, but they have a highly receptive uterus, they can often get pregnant but miscarry. Successful pregnancy is really when you have a nice, perfectly genetic, normal embryo and a good receptivity of the uterus. And that's one of the reasons why a technique has come, into the IVF world, called pre-genetic testing for aneuploidy. So once you've created an embryo, you do have the option of doing an embryo biopsy, which we call PGTA. So here you can see an egg being fertilized by sperm in the laboratory, creating obviously the embryos that we've just talked about. And as that embryo is developing, it has cells on the outside, and we can take a biopsy of just 2 or 3 cells, it's normally 3 to 5 cells, and send them off for genetic analysis, telling us that the embryo is either genetically healthy or not. And the beauty about this is that when we come to select the embryo for replacement with a PGTA genetically tested embryo, you move your chances of pregnancy, perhaps from 40% to 80% plus. And I think sometimes for people, knowing that they have a genetically healthy embryo being transferred gives them that reassurance. It is more costly, it's a little bit more invasive, and you do have to freeze all the embryos whilst you wait for the genetic results. So, it takes a little bit longer to get to that point where you're doing embryo transfer, but we're seeing more and more people asking for PGTA. It's much more common in America. Little few slides here on how to choose a donor. I'm just going to give you the rules. Okay, so in the UK, all donors have to be identifiable. So even if you import donor eggs and donor sperm from abroad, we have to, as clinics, ensure that those clinics abroad that have the donor sperm or eggs are collecting the sperm and conforming to the regulations that apply to our country. And that is that the donors have to be identifiable to the child when the child comes of age. Okay, they have to be screened, they have to have a medical screening, psychological screening, sperm quality screening, and full sexual health screening, screening for chromosomes and cystic fibrosis. The donor has no legal rights on the child. You are the legal parents, and the donors are only entitled to know about the number of children, if any, conceived by their donation, the year they were born, and the sex. they can create up to a maximum of 10 families in the UK. That doesn't stop them creating more families with their sperm or eggs abroad, but only 10 families in the UK. So, for example, anonymous sperm donors the criteria would be that they would be aged under 45, because we know that genetic quality of sperm declines after 45. Normal sperm parameters, negative results for HIV, hepatitis B and C, syphilis, gonorrhea, CMV, HDLB1 and 2, normal chromosomes, normal male chromosomes, normal genetic screening. And there are numbers of banks, both in the UK and abroad, that you can select donors from, and the sperm will come frozen. The same goes for eggs. Now we do more and more frozen eggs, because you at least know what you're starting with, as opposed to waiting for the egg donor to have a cycle. Obviously, if you're using a known donor, the egg donor will undergo the IVF cycle to freeze eggs. Egg donors have to be 35 years old and younger. Donors are not supposed to be paid more than the amount of money that it costs them to have treatment, to come to the clinic and have treatment and screening. So we can't use a lot of them. Some of the banks in the US, for example, will pay their donors large sums of money. We can't use them in the UK. But as long as the donor bank complies with UK regulation on costs, there are some in the US that do, we can use it. We can import that sperm or those eggs. So choosing your donor is a very personal thing, and it's often based on characteristics. You'll go onto a donor website. The clinic cannot choose the donor for you. The clinic can only guide you as to what you need to look for. You can look at ethnic origin, eye color, skin color, characteristics that, particularly that you like, and particularly think about choosing a donor that you might be able to use for a second or third child. They will give you obviously the results, and they can now do enhanced genetic screening. It's called carrier screening. I haven't got time to go into that, but the donor banks themselves can give you counseling around extended screening. Jumping now onto surrogacy. Surrogacy is a complex, very complex pathway. We do a lot of surrogacy here at the Agora Clinic, and I do have educational videos on all the different treatments we're talking about tonight, as well as good content on the website. So if you do want to know more about surrogacy, contact my dedicated surrogacy team, because I can't do it justice in just a few minutes, as I will be doing tonight. But when you're considering surrogacy, as perhaps same-sex parents, you're going to have to consider potentially straight or gestational surrogacy. Now, in gestational surrogacy, you will be using donor eggs, and the surrogate will be a different person. So the egg donor will be used to create embryos with your sperm, and then the embryo can be transferred into the surrogate at a later stage. In all cases, it's either the sperm that has to be first frozen and then quarantined for 3 to 6 months, or embryos created with the donor eggs, then they have to be frozen and quarantined for 3 to 6 months before retesting for all those sexual health conditions that I mentioned before. And this is what happens actually with donor sperm and donor eggs. No donor sperm or donor eggs can be released for use until all the sexual health screening has been repeated 3 to 6 months after the donations. In straight surrogacy, the same person provides the eggs as the uterus. So, for example, insemination of the intended parent sperm can be used. And that can work very, very nicely. Or you can do IVF, but most of the time with straight surrogacy, we find ourselves doing insemination. As I mentioned before, the chances of success when you're using normal sperm or donor sperm is around 15% chance of a pregnancy per insemination. So things to consider when you're considering is, do you both want to be biological parents, or is there just one that would like to use their sperm? Do have both sperm, your sperm test done, potentially with DNA fragmentation. You can improve your lifestyle if your initial result isn't good. 3 months of making lifestyle changes, taking vitamin supplements, changing your diet, stopping alcohol, stopping recreational drugs, avoiding hot baths can sometimes make quite a good difference to sperm health. When you're ready to freeze your sperm, you would have some screening tests, which are exactly the same that we use for sperm donors. So chromosome, cystic fibrosis, HIV, hepatitis, syphilis, gonorrhea, etc. You then come in on normally 3 occasions to produce sperm samples, which are frozen. You normally need to leave 3 days between each sample. Those are sort of prepared, centrifuged and frozen. And then either 3 or 6 months minimum after the last sample is produced, you have repeat screening tests, not the chromosomes, just your sexual health screening tests like gonorrhea and HIV. And then that allows the sperm to be released. In the situation of freezing sperm, you are then going to be able to create embryos that can be transferred fresh into the surrogate. But you also can do quarantining of embryos, in which case the egg provider, usually your donor egg or frozen eggs, can be mixed with your sperm to create frozen embryos. And the route you choose is one that we discuss in clinic. We can discuss what is best for you depending on which donor you're going to use. And the outcomes are the same. Usually the costs for us, the costs are very, very similar. There isn't one preferred route, but it does depend on your situation, whether your donor's ready, we found a donor, but you haven't found a surrogate. All these questions are ones that we consider. So we create an embryo to freeze. And the typical IVF cycle is once we have embryos, we prepare the surrogate either in a natural cycle, but remember we prepare the womb lining so that the embryo transfer can be taking place in a well-progestinized environment. Often with a surrogate, they will prefer not to use medication. Surrogates, briefly, recommended age is that they've ideally had a pregnancy. They're not too old. They hadn't got any complications. They may have had a cesarean delivery, but that's not a particular issue. They are healthy, so that being pregnant doesn't carry a risk to either them or to your baby. We screen them for conditions that could be passed on to the baby, and we basically know that different clinics will have different criteria, but that's very much a question of which clinic you choose. Final slides are on trans fertility. Now, having done all that sort of preparation to explain how eggs and sperm can be frozen, for example, sperm frozen for intended parents and surrogacy, or egg freezing, you can see it's all the same, but the pathways that we take, when you're transitioning, it's quite critical to get the timing of your freezing right. So we normally know that it takes a little bit of time to get assessed at the GI clinic, and certainly here down in Brighton, we're seeing patients that haven't actually had an appointment at the NHS GI clinic. They have been seen by the GPs, they've been referred properly to us, and they're usually socially transitioning and preparing for hormonal transitioning, and we do the fertility preservation at this point. And we then don't see the patients possibly until they have, found the relationship that they want. They've done perhaps some physical transitioning in terms of, chest surgery, whatever it happens to be. And then we've got frozen eggs or frozen sperm to use. Just some key markers in terms of freezing eggs, exactly as I explained before. Once the eggs have been collected, we will freeze. But things that people get a bit anxious about is the intimate examinations. Here we're I see that very frequently trans folk here, and we just talk through what's acceptable, what can you cope with, and if we can't, monitor transvaginally, we will try our best. Transabdominally, we can use transabdominal examination to see the ovary. You will need some basic fertility tests to make sure we know your egg reserve, to get the hormone dose right, to collect the eggs. We would always advise you to have the necessary screening tests to make sure that the eggs can be used in a surrogate in the future, because that might be a pathway. You're not ready to decide quite which pathway you want now, so we just do all the required tests. Forms are completed, and they will be in the names, the name that is on your legal paperwork. it may be that you haven't changed your passport, you haven't got a gender recognition certificate. It doesn't matter, you can always change your names on the forms later. And how long will it take? Not long at all. If you're working with a good clinic that's used to doing this, it can be done very quickly. A matter of weeks, really is. We do freezing for patients here on the NHS who are transitioning, as well as for cancer patients. We can freeze eggs within 3 weeks of, within 3 weeks the whole thing's done, of being referred, but because time is of the essence, but we can take longer as well. Sperm freezing, it's really important to get an idea of what the quality of the sperm is like and whether we can use it. So we would ask for a sperm test to be done. Then we ask you to not ejaculate for about 3 days to get a representative sample. We then discuss the result with you, and we would then suggest you come in having obviously tried to optimize your sperm quality. Most times people are keen to get onto the hormones, the cross hormones. So we'll work with any quality sperm, to be fair. In the future, if the sperm quality is poor, we'll probably have to do IVF using ICSI. Again, we need to get the blood tests done to prepare the sperm. It's screened as if it's a donor sperm sample, so it can be in the future used in any situation, including that of transferring into a surrogate. And the same issue about names and process from referral to completing the process can be 2 weeks or less, and about 3 visits, because we would normally suggest 2 or 3 visits to produce a sample. Things that can become difficult if you are tucking, that can cause heat to the testicle, because the testicle is kept outside the body at a lower temperature than body temperature. It's about 34.5 degrees. So if you're tucking, that pushes the testicle into a higher heat environment. So don't tuck, try and avoid that, avoid smoking, avoid recreational drugs, eat a healthy diet, ejaculate fairly regularly every 3 days. You will improve the sperm motility. That's just general tips. What to look for in a clinic? Okay, I've been, lecturing professionals for 5-6 years on inclusive fertility, and it's something I'm really passionate about. When you're looking at a clinic, you've got to feel comfortable. You've got to know that that clinic is inclusive, and the approach is across everything. Start by looking at the website. That's a picture of our website. And it immediately, if you can see that you go on there, there will be a pathway that you can immediately relate to. It tells you this clinic is perfectly happy and used to and loves working with people from the LGBT community. We fly the rainbow flag. We don't choose Pride Month or anything. We have a rainbow shawl on our baby, because it just tells you, okay, we're really happy to welcome you. You are part of our community. But we're in Brighton. I guess that's our community here. We have people from all sorts of different backgrounds, heterosexual, same-sex couples, all come to our waiting room, and everybody's welcome. Have a look at the website. Look at the promotional material. It shouldn't be heteronormative. It should cover everything. There should be posters in the clinic that look at, donor sperm treatment, surrogacy, and so forth. Have a look at the staff. Do they, can you see yourself in the staff? Is this an inclusive, diverse organization? See if they've asked you about your pronouns when they introduce themselves, when they talk to you. Are they, are they careful with their forms? Are they offering you the opportunity of using gender-sensitive forms? And all that will immediately tell you, yes, they've got experience of people like me. Don't over-focus on success rates, as I mentioned before. Make sure that they consider accessibility, not just disability in terms of accessibility. Make sure you can get there. Make sure they can go do Zooms and online consultations to save you unnecessary travel. Big thing on emotional support. They should be offering you emotional support. A really key part of that is counselling, which really is part and parcel of every fertility journey, not just an LGBTQ plus journey. Make sure they've got good educational material, good ways of communicating. We use a patient app which allows us to have very rapid communication with our patients. Look at the reviews and go onto the HFEA website, choose a fertility clinic, look at their reviews. If we use Doctify, which is a trust, it's like Trustpilot, but for clinics, and it means that only patients can actually write those reviews. They can't be fake reviews put up by the clinic on Google. And just walk in the clinic, visit, and see, how does it feel? Okay, how does that clinic feel? And yeah, that's our clinic. We love green, and that's our laboratory. And you know, we actually have a glass door so you can see into our laboratory, so people can actually visit a clinic and see what it looks like. Final slide, just on cost, because I know people will want to ask me. I just want to give you some pointers. Cost is very clinic specific, but don't be fooled by the headline price. Make sure you ask the clinic before you get involved in a clinic, what exactly does that cost involve? I only do package costs. That is what a cycle of insemination costs. Medication isn't usually required. We have 3 cycle packages. That is what you'll pay if you do IVF. It'll cover everything, your scans, your egg collection, everything. Don't, you know, if they've got, they've got things that they add, you want to know the full final cost. So when you look on the website, click, and normally a drop-down menu will give you the full cost. Don't look at the ones that say starting at 2,500, because it'll end up being a lot more. Medication is usually separate because it's very patient specific. Shared motherhood is often 1.5 times the cost of straight IVF with your own eggs and you having the transfer. And many clinics like ours offer egg sharing, where you donate half your eggs to somebody who needs donor eggs, and that takes the cost, as you can see, right down. So I'm just going to hand back at this point to offer the opportunity of questions to be answered.
Oh, Dr. Carole, thank you. That was incredibly informative. Like you said, if okay, we'll go straight into questions. We've got a few already, but if anyone else has a further question they'd like to ask Dr. Carole, just pop it in the Q&A tab, and that should appear at the bottom of your screen. So you've touched on it already, you've answered the question, but I promised I'd ask. So how much more expensive is shared motherhood?
It will depend on the clinic, and it will depend if the clinic is adhering strictly to doing all the donor screening tests. Some clinics, we are aware, are putting a huge uplift on those tests, which is not necessary. They don't need to be extremely expensive because they're simple tests. But some clinics like ours are offering you the option not to be screened. To be screened, if you like, as a heterosexual couple would be screened, where the sperm provider is not screened as a donor. So you can actually look at it as being about 1.5 times the price of IVF.
Thank you. The second question then. I am 32 with an AMH of 8.8. No other known fertility issues, but I've also never tried to get pregnant and never had sex with a man. I'm a lesbian but single. Should I do IUI or IVF?
Yes, I think you're not, your AMH is lower than average for your age, but it doesn't tell me anything about your egg quality. Your age tells me that you should have reasonably good egg quality. My advice to you, if you're single and you aren't completely ready to have a baby, is to have a cycle of egg freezing or 2 to preserve your fertility, and then consider donor sperm insemination. Because then if it doesn't work out and you have to consider having IVF treatment, you know what it's like, and you may want to use some of those eggs. But if you do get pregnant, then when you come back 2, 3, 4 years down the line to have a second child, you may find your fertility has dropped right down. You've got your eggs frozen, so you know you're in a good position.
Thank you. The next question then is in 2 parts. So we are a gay male couple. We have a surrogate, but she doesn't want us to use her eggs. Are there many eggs in egg banks in the UK? Do you know? Will we have much of a choice? And then the second part. Also, can we mix our sperm so it's a surprise who the genetic dad is?
Lovely question. First question answered is, there are many sperm banks, not just in the UK. There aren't that many in the UK. There aren't that many egg banks in the UK. There's quite a lot of difficulty recruiting donors in the UK, but there are a lot of egg banks in Europe and also in the US and further afield. We do not, for example, have a wait time in the UK in our clinic for donors if you're happy to go abroad. And we use frozen eggs, which have equally high success rates to using fresh eggs now. And you won't, you could within 2 or 3 months have your donor selected. So you don't have to use the surrogates eggs, and you can choose your donor and be on, create embryos very quickly. Most surrogates will probably be more happy to go in a situation where embryos have already been created. And they will be more likely to, for example, if you go to Surrogacy UK, we know they like to work with IPs that already have embryos frozen. Second question, sorry, no, you can't have surprises. We have to be regulated by the HFEA, so we have to know who has provided the sperm and who has provided the egg when an embryo is transferred into a surrogate. So you can't mix, and you can't put more than one embryo back into a surrogate, because that would increase their risk to them, particularly of twin pregnancy.
Thank you. The next question then, why do we have to do implications counselling and welfare of the child forms?
You are not I am, singled out as people from the LGBTQ plus community for either. Implication counselling should be offered to anybody who is using donor eggs or donor sperm, so that they have an independent view from the clinic professionals on some of the implications of using donor eggs and sperm. I think this is something that will be touched upon by Nina from the Donor Conception Network, with whom I work closely. But, there's so much information that you need to sort of have on board when you parent using donor gametes, donor eggs or sperm. And the counselling is there to support you and guide you, talk to you about legal parenting, legal parenthood forms, what to tell the child, when to tell the child, where to access resources to support you. We don't make implications counselling compulsory. We offer it to everybody. Some clinics will make it compulsory, but it isn't an assessment. Nobody is there to assess your ability to parent. Likewise, welfare of the child has to be completed by the clinic, but from a regulatory point of view, we have to make sure that no future child or existing children could be affected if we create children through IVF. Which is why the welfare of the child has been in place for since 1991, when the HFEA was formed. But we're there, in clinic to identify cases where there might be a need for social services to get involved, where there might be potential risk, with child abuse. Somebody may have had, been in prison for something. They might be living apart, and there might be potential domestic abuse going on. We're there to protect everybody, including the future child. It's not there to deny people treatment. It's there to work with individuals or couples to ensure that we prepare you for parenting, and we only start the treatment when everything is safe.
Thank you. Next question. I have a very tilted uterus. Will any stage of IVF, especially egg transfer, be painful? Is there anything my doctor can do to reduce pain?
Unfortunately, some people do have a uterus which is what we call acutely retroverted, and it can make the transfer a bit more tricky. Most clinics will be able to offer you some form of sedation for transfer. They should run, we do a trial transfer on anybody that we predict might be a little bit difficult, so we prepare ourselves and we sort of map out the transfer. Our consultant will do it. And there's nothing that can usually be done to correct the angle. We work with it, but we can try and make it as comfortable as possible. A lot of my patients with an acutely retroverted uterus are absolutely fine. They don't need additional pain relief, and we use a full bladder, and just as long as we know about it, we're quite expert at getting the embryo into the uterus.
Thank you. I had eggs frozen in 2011. I've had to self-fund storage. Can you offer any advice on getting NHS funds to cover this? Also, I plan to donate my eggs if I don't use them, for example, to a friend. How does that factor into the treatment options?
So it's unfortunate that NHS funding for anything is determined by where you live, and the ICB, that Integrated Care Board, that exists in your area. So you should get your GP to write on your behalf to see what could be done or funded. I suspect nothing can be done because you froze your eggs at a time when the funding wasn't in place, and they don't tend to retrospectively suddenly start to fund it. Can you donate your eggs? Again, it's going to depend whether the screening tests were done before you froze your eggs. So if you're donating to a friend and the screening tests were not done, they can do some retrospective screening and risk assessment, and your friend might be quite willing to consider that, knowing, you know, that you're healthy, your background, you're low risk for having any STDs.
Thank you. It looks like we've come to the end of the questions. So thank you so much, Dr. Carole, for giving up your time this evening and sharing your incredible expertise, and importantly, for being such an ally for our community and an advocate for LGBTQ plus families. For those joining us next week, we'll be joined by Adoption UK, and you can join on the same Zoom link as tonight, so please keep it safe. You can also email me. It's bethan@fertilitynetworkuk.org if you've got any questions or need the link resent. But thank you, everyone, and have a lovely rest of your evening, and I will see you next week. Take care. Bye-bye.